Right, well, I think we'll make a start. Welcome everybody to our second webinar on blood pressure. This time we're going to be focusing on management. The session's going to be led by Dr. Philip Lewis, who I will let introduce himself. We're running these sessions through the Stroke Network because we're part of the BP at Home programme that NHS England are running. So this is done to support that, but it is also applicable for people who are involved in monitoring blood pressure with patients. So
my name is Philip Lewis. I'm a cardiologist and a hypertensivist. I spend most of my time halfway between the two, but all my clinic time now is almost all hypertension. And all my research is on hypertension too, and particularly in the world of blood pressure measurement. So I want to talk today about the blood pressure monitoring at home and relate it particularly to stroke, since this has been done on behalf of the Stroke Network. So first of all, why home? Well, if we look at a large study of the difference between clinic readings and home blood pressure readings, or clinic reading, but in this case, we use home blood pressure readings using a 24-hour ambulatory blood pressure monitor. In just about 40%, the clinic reading and the ambulatory blood pressure reading were the same. And that we would, from now on, we will call sustained hypertension. They were both, this is a hypertensive population, both were elevated and the readings were the same. Now, in 11% of this population and 15% of others, the home readings on the 24-hour one were higher than the clinic readings. So someone in the clinic would say, you've got a perfectly normal blood pressure. But in fact, it wasn't normal the rest of the time. And that's called masked hypertension because no one can see it. And then in this population, 50%, the clinic reading was significantly higher than the 24-hour blood pressure reading. And that's white coat hypertension. So with that in mind, why should that matter? Well, because it's not your clinic reading that predicts your cardiovascular risk best, but your home blood pressure reading, either measured as using a home blood pressure monitor, which the BP Monitoring at Home project does, or using an ambulatory monitor. So 40% of people had a clinic reading which was the same as the 24-hour reading. 11% of people had a clinic reading which was normal, but their blood pressure was at home over the 24 hours was much higher. And 50% had a blood pressure which in clinic was high, but at home was normal. That's white coat hypertension. Now, this is very important because it's not the clinic reading that best predicts what's going to happen to you, whether it's stroke or any other form of cardiovascular disease, but your home blood pressure or your 24-hour blood pressure. And the other thing is you have to be careful not to label people as normal just because they've got white coat hypertension, because here's a slide of cardiovascular events in untreated patients. And you'll see that this bottom line here, these are people with normal blood pressure. And over 12 years, they will have just about 6–7% of them will have a cardiovascular event in this population. If we talk about people who've got sustained hypertension, you'll see that over the same time, over a quarter of them have had a cardiovascular event if they're not treated. If they've got masked hypertension and they've not been treated, then their risk is somewhat less. But even the white coat hypertensives here still have a greater risk than normotensive. So what is white coat hypertension this week may not be in a year's time. Now, if we then look at this next slide on the right, this part of the slide on the right, we'll see that in this group, these are people who've been treated. So the blood pressure that the doctor or nurse or whoever sees in clinic or at home is being treated in an attempt to get to target. And here, white coat and normotensive seem about the same, but here's the risk of those people who've been treated who are known to have sustained hypertension. But you see the risk here on the top line of people who've got masked hypertension is much higher, because the treating clinician has been fooled by the blood pressure apparently being normal in clinic, but it's much higher at home. And this, you can see here, we've got risks here of over nearly 40% at 12 years. And this is the most dangerous group of all, people who don't know their blood pressure is higher at home. They're just treated, and there's this sense of safety in clinic, but it is a false sense of security. So technically, white coat hypertension is when the blood pressure is normal in clinic and high at home. White coat effect is when actually they're actually hypertensive anyway, both in clinic and at home. Now, the other interesting thing is that the percentage of white coat hypertension varies depending on what your blood pressure is. So the white coat effect, if you want, in people who've got normal blood pressure, estimates the clinic blood pressure risk, overestimates your blood pressure by about 2/4. If, on the other hand, you've got a blood pressure which started at greater than 180/110 in clinic, that blood pressure may be as much as 40/20 higher than the ambulatory reading. That's a huge difference, isn't it? 40/20 higher. So you can see that if someone's apparently got high blood pressure, I'm not sure I would want to be judged based on my clinic reading when it overestimates by 40/20. And you can see the danger here is that you'll pile on drug after drug after drug with adverse effect or side effect after side effect. And in fact, your risk blood pressure may be quite normal. At the mild hypertension stage 1, you'll see 13/10 is the average overestimate, and stage 2, that's between 160 and 180 effectively, 24/14. So I hope from that slide alone, you'll suddenly realize that if someone's got blood pressure, you will not want their blood pressure, or if it were you, your blood pressure, treated on a clinic reading, because someone will have a totally false understanding of what the blood pressure is. Now, it's slightly more complicated in the fact that you can have systolic masked and white coat hypertension, diastolic masked and white coat hypertension. You can have nighttime masked or white coat hypertension, but I'm not going to dwell on that. It's just that each of these have separate risks to some extent, but you just have to be aware of it. So the most important thing is the masked hypertension, whether it's daytime, 24-hour, or nighttime masked hypertension. They are particularly at risk. But the thing that we're going to make decisions on is based on home blood pressure averaging in our own work here at the moment. Now, the other thing, of course, is, well, I've already talked about the fact that you can have ambulatory or home blood pressure readings as the criterion of what your risk is. But if you look at this study, which used people who had both ambulatory and home blood pressure readings and clinic readings, then it gets a bit more complicated. So this sustained group, they had true sustained high blood pressure. It was high in clinic, high on the ambulatory reading, and high on the home readings. Complete masked hypertension, whereas the home and ambulatory readings were both high and the clinic readings were normal. You see they're very high risk. Partial masked hypertension, when it was either the home or the ambulatory reading was high, but not both, and the clinic reading was normal. And you can see that partial white coat hypertension, this is the effect of stroke, is not a safe thing to have where the home or the ambulatory reading was high and the clinic reading was high. Complete white coat hypertension is when the clinic's high, normal home and ambulatory readings are there, and this is what happens to sustained normal. I'm sorry to complicate it, but just understand that there is a slight difference between some people have high home readings, others who have high ambulatory readings, and some who have both, but most people don't have them both measured necessarily. So we've talked about cardiovascular risk, but does blood pressure control help after stroke? Because what I hope you'll understand is that you've not only got to be well informed yourself, but you've got to be able to motivate your patients and their carers to put up with getting blood pressure measured at home and understand it's important and understand that it's important to get to target. So does it help after stroke? The answer is a very resounding yes. How much does it help? Well, lowering blood pressure reduces the risk of recurrent stroke by 18%. And for every 10 millimeters of systolic blood pressure reduction, you have a 33% reduction in recurrent stroke. That's worth going for, isn't it? So the rule is keep calm, treat to target. The target is important. So this is a summary slide, and I'm going to go into two particular bits. The primary prophylaxis area here, people trying not to have a stroke in the first place, or you're trying to make sure they don't. This is particular. I suppose this is obvious in people who've got an awful family history of stroke. You want to make sure they're hypertensive. You want to make sure their blood pressure is treated to a clinic target of less than 140/90, which would be equivalent to a home target of less than 135/85. And then we're going to look at the secondary one. This secondary prophylaxis. This is people who've had a stroke. They've recovered from either an ischemic stroke or a TIA, and they still have a blood pressure equal or greater than 140/90. And I'm going to go into this. I'm not going to talk about acute ischemic stroke or acute hemorrhagic stroke, because that's not in the remit of today. So in terms of primary prevention of stroke, you want to make sure that blood pressures are treated to an average daytime blood pressure, whether on ambulatory average or home average, of less than 135/85. Now that's the theory, but of course in some people you've got to think of their frailty, their dependence and comorbidities. And in some people, if you go too low, they feel weird, or the blood pressure, they can't cope with a lower blood pressure. And I'll talk about that, maybe due to postural hypotension. It may be because they've got areas of hypoperfusion in their brain that can't tolerate lower blood pressure. So we'll talk about that later. But in terms of but that's in people who've had a stroke. This is people who haven't. Aim for 135/85 if you can. The HYVET study, Hypertension in the Very Elderly trial, suggested that in people over the age of 80, you should think about blood pressures averaging less than 150/90 in clinic or less than 145/85 at home. So now we're going to go into this other sector, the secondary prophylaxis, people who've had a stroke, from which they've recovered. In terms of secondary prophylaxis, that's people who've had a stroke and we're trying to stop another one. It's frightening that 25% of strokes are recurrent. 4% every year are going to have a recurrent stroke. And that the mortality for this second stroke is 41%. That's absolutely huge. So that means that for TIAs and minor ischemic strokes, 6.4% will have a cardiovascular event in the next year, and 6.4% in years 2 to 5 as well. Now, it doesn't matter what patients are treated with, getting them to target is absolutely essential. The guidelines don't suggest that beta blockers are ideal, but sometimes they be necessary for people who've got angina or tachycardias and things like that. But the Royal College of Physicians guideline for stroke management suggests that a clinic reading of 130/80 or less would be appropriate. Now that's equivalent to a daytime average blood pressure recording of less than 125/75. Hard to get to possibly, but that's the guideline, and there is advantage in getting to there if it's at all possible. Obviously, if people have got carotid stenoses or occlusions, they may not be able to cope with that. They may feel positively lightheaded. And in that case, you try and get as low as you can, certainly a drop of 10/5 if possible, certainly down to 140/90 if possible. But whatever is tolerable is better than no blood pressure drop. Now, remember that blood pressure management is just not giving them pills. And when you do give them pills, it's very important that whoever's treating them is aware of what else might be going on, because some people get so hooked on a number that they forget that it's a patient they're dealing with. So If someone has impaired glucose tolerance or type 2 diabetes mellitus, for instance, and you've got hypertension, which is not easy to control, then a wonder drug in this group of people would be the SGLT2 inhibitors, such as empagliflozin, dapagliflozin, canagliflozin, which have the advantage of not only being able to reduce weight, but also reduce blood pressure, improve glucose tolerance, and if you have heart failure, even improve that. Sleep deprivation can put blood pressure up, so don't give diuretics at night, and sometimes any diuretic will keep people up at night, so if it's possible, try and avoid nocturia. And if you can use long-acting drugs so it doesn't disturb them in the night in any way, that's also important. If someone's blood pressure is not falling, or they're obviously rotund, ask about whether they snore. Sleep apnea accounts for resistance in hypertension in up to 80% of cases. So typically it's a man with a 17-inch collar or wider who has a history of snoring. His partner says he stops breathing in the middle of the night. There's a questionnaire which is worth using for this called the Stop Bang questionnaire. It's an 8-point questionnaire that helps differentiate between people who are at risk of sleep apnea and not. It's worth using, but always think of it. And if you see someone who's got a thick neck or who's hypersomnolent, just ask about snoring and do a Stop Bang questionnaire and refer them appropriately to a respiratory team for further evaluation. And of course, if patients had a stroke and they're not excessively mobile, then amlodipine is a wonderful long-acting antihypertensive drug, but I sometimes call it ankle swelldipine because 20% of people may develop ankle edema with it. So it wouldn't be the ideal drug in people who've already got ankle edema or have got varicose vein disease and who are hanging around a lot. Think of another calcium channel blocker, possibly lercanidipine in the Northwest, as an alternative which is less likely, but not totally unlikely, to reduce edema. And also, if people are getting lightheaded, don't forget that when they stand up, don't forget to check their standing blood pressure. And this is a real nuisance in people, men who are taking tamsulosin for prostate disease and anything that has any alpha blocking activity, doxazosin for blood pressure, amitriptyline is a hypnotic or an antidepressant, all of which have alpha blocking activity and can cause a significant fall in standing blood pressure. And what happens is the patient says to us, I don't like those drugs, I don't feel well. And what they're actually saying is my blood pressure when I stand up sometimes is just too low, and that's why they don't feel well. And it's worth knowing why they don't feel right on the drug. And of course, some diuretics will drop blood pressure particularly, but not in everybody. So just to think of other non-blood pressure related factors that we have to take into account in reducing stroke: smoking, statins, sticky platelets, and silent AF. No one's ever recorded it. During the stroke admission, it had not been noted. There was no monitoring done. And if there was someone's had a stroke with normal carotids, with no, with reasonable blood pressure, the stroke couldn't be accounted for. This might be one of the patients to think of, particularly using the Omron Intelli M7 machine as an ideal patient looking for AF detection. And the other thing to consider, is sometimes that patients who have none of the above, and certainly recently I picked up several of these, patients who have a septal defect due to either a full atrial septal defect or a patent foramen ovale. It's something that always consider from a medical side if you haven't accounted for the stroke. Sometimes all you may see on an echocardiogram is a rather mobile interatrial septum. So what do we know, first of all, about ambulatory blood pressure control after stroke? Well, stroke survivors tend to have a disrupted day-night rhythm. The blood pressure doesn't often go down as much at night. Now, that's often because of the effect of the stroke on the brain. Sometimes it may be due to them having secondary hypertension, like patients who have hyperaldosteronism, Cons syndrome, may have nighttime elevation anyway. In most stroke patients, the nighttime blood pressure is less obvious, but 24-hour blood pressure still predicts vascular events, dementia, cognitive impairment, and recurrent microbleeds. So we know that it's an important factor. So now we're going to go on to self-monitoring and self-management of blood pressure. Now, in this trial here, patients were either put on usual treatment, that was just clinic readings and adjustment of treatment on that, versus home blood pressure readings, and then the treating clinician would adjust the blood pressure treatment, or self-management, where the patient would not only know what their blood pressure is and what the target was, but could then adjust a variety of drugs they were given to improve their blood pressure target. Now, and this was the daytime average blood pressure in the groups after they'd been treated: 130.8, 128.2, 127.8. So the mean systolic blood pressure reduction on usual treatment was 3.3 millimeters mercury, and in self-monitoring, nearly 7 millimeters mercury, much better. This is advised by the treating clinician, which is this one as well, but advised on home blood pressure readings. And self-management wasn't quite as good, but you can see that self-management is a vastly more expensive process at an extra cost of £1,000 a patient, where self-monitoring at 196 can be good value, depending on what you're doing, and it's something to be taken into account. So, is home blood pressure versus... Sarah, I didn't touch that, the screen's changed.
Okay, I will just share the slides again. I don't know what's happened there. They seem to have collapsed themselves. 1 second. Just loading, 1 second. There you go. If you take control and then move yourself back. I've no idea what happened there. That's the joys of Teams.
It's the second time it happened.
You need to take control.
Oh, sorry, yes, I'm just moving through, so thank you. So for every 1 millimeter blood pressure reduction, it costs another £196. So you could say, is this worth it? In terms of the value you can see from what eventually, that's just this is only in 6 months, but it doesn't talk about the high risk of particularly in recurrent strokes. And this was just used, so I think that we have to just understand that, but that's not a final answer. So if we look at the sort of blood pressures you would expect at 12 months, self-monitoring will give you a 3.5 millimeter blood pressure reduction, telemonitoring just over 4.5, with very little increase in the number of drugs. So self-monitoring certainly, or telemonitoring where it's managed at a distance. And so self-monitoring, you send off your blood pressures to somebody. Telemonitoring, there's some automation involved, can be highly effective. And then, so the next thing is, to what degree should you try and get the blood pressure down? Well, this is a trial looking at either standard treatment aiming for blood pressure and achieving a systolic of less than 135 versus more aggressive control of getting down to less than 130. And this 5 millimeter blood pressure reduction reduced the recurrent stroke rate by 22%. Now, that's a relative reduction of 22%, but you've got to understand that relative reductions and absolute reductions are two different things. So that there, as you can see, is just about 8.5%. That goes down to just about 7.4%. So there's, or just about 7%. So there's about a 1.5% absolute, 1.5. So 3 patients in every 200 will, after 5 years, have not a recurrent stroke. So one has to be careful of this business of absolute versus relative reduction. So that's all very well, but we're not doing very well. In this 2004 study looking at people between 1994 and 2011 in the UK, 37% of people were controlled to a blood pressure of less than 140/90, despite 71% being aware of their diagnosis and 58% of people being on treatment. Only 20% of people with a cardiovascular risk of more than 20% were controlled, and 57% of people with type 2 diabetes. Presumably it motivates them better, but basically we are not doing well in control. So the results of failure, of that sort of failure of control, well, if you had angina, hypertension reduces the disease-free life years by 43%. If you have heart failure and stable angina, we're talking about a 38% reduction in so-called disease-free life years. Intracerebral hemorrhage, you're putting people at an extra, if you don't get control, an extra 44% risk. Subarachnoid hemorrhage, 43% increased risk. Stable angina, about the same. And so if the blood pressure remains equal or greater than 140/90 on they're on treatment, the risk of developing cardiovascular disease from the age of 30 effectively is a 63.3% lifetime risk, compared with if their blood pressure was normal, which is almost 20% lower. So blood pressure, as you know, is a risk of stroke, heart attack, heart failure, kidney disease, cognitive decline, premature death. For every 2 millimeter rise in systolic blood pressure, mortality increases for 7% for heart disease and 10% for stroke. So when we're talking about these small advantages of home blood pressure monitoring or telemonitoring, we're talking about a significant change in stroke or heart disease mortality. And since primary care consultations account for £2 billion and now more, it's a huge amount of cost. Now I'm going to stop there, and then we're going to personalize it at that point. So I'm stopping for questions at the moment. Hi,
thank you, Philip. We've got two questions. The first is from Lydia in Trafford. And this was done a while back, so we've gone past it. Does a clinic reading include a reading taken by a healthcare professional at home?
No, it doesn't. Clinic reading was a hospital clinic reading. And so I suppose the implication is that if you do several readings at home, would you get as good blood pressure? And I know that most people don't have the luxury of being visited at home to have their blood pressure measured. So no is the answer. Not in that study. And unfortunately, I can't think of a study, and that's my ignorance. I can't think of a study. I'll have to look it up to see whether that has been done. I don't know that one. Sorry about that.
Okay, second question is from Jennifer, who says it might be slightly off topic, but when measuring blood pressure as one-off, i.e. 3 readings, in their case for a research study, at what point would you look to inform a clinician of high blood pressure? Our initial thoughts was to seek advice if the lowest reading was 180 over 120 or higher. So I'm guessing Jennifer's involved in some sort of research.
Well, I think certainly you have to at that level. That would be irresponsible not to. But whenever you see a blood pressure of 140/90 or above, that person is at technical increased risk. So the rule is that whenever blood pressure hits 140/90 or above, having stabilized, as in the study where you've done in this research study various readings, I think you've got you have a responsibility to tell the patient their blood pressure was above 140/90, and the current guidelines are that they should see someone about it for further advice and evaluation, and it may well prove normal, but that's not the point. Okay, they don't have to do that straight away, but my feeling is if the blood pressure is hitting 160 or 100, then you have to tell the patient that their blood pressure is possibly clinically significant, and they ought to be asking for a primary care assessment within a month if they can. It doesn't mean to say, you have to reassure them on the one hand, it may not be sustained, they may not be at risk, but it would be irresponsible not to let them know that. And when you're talking about 180 systolic, at that point, they need to see someone within the next day or two. If it's too, basically the rule is that at that sort of level, they've got to see someone within the week. If it's above 200, they should be, and you're in a research setting, then shouldn't you be phoning up somebody and saying, what should we do? And it depends on your trial protocol. You may well, as we do, set up the business that if someone in a blood pressure validation study that I was doing recently, if the systolic hit 180, we would not only inform them that they would not be allowed to continue in the study. But that wasn't a hypertension study. That was a study of blood pressure monitor validation. So I hope that helps. What are we going to do about the blood pressure anyway? Well, first of all, if you can, this is what I do. If I can, the first time I meet anybody, I want to know the blood pressure in both arms, because it is quite likely, especially in older people, there may be a significant difference between the two arms. Now that difference may not be anatomical. In one study from Exeter by Chris Clark and others, they showed that if you see a significant difference in arms, that does increase cardiovascular risk in its own right. But sometimes, if someone's had a radial angiogram, for instance, coronary angiogram through the right radial artery, often the blood pressure in that arm may be quite abnormal because up to 25% of the arteries don't work as well, or didn't in the past anyway. So one easy way to check it is, first of all, to feel both radial pulses simultaneously and see if there's a delay or any difference in strength. Ask for history. And then if there's still a difference, think about the possibility that a giant cell arteritis, or much more likely a atheroma of the subclavian artery or brachial artery, may cause a fall in reduced blood pressure in that arm. And of course, a stroke arm may have an abnormal pressure anyway, because it's been underused and the flow may be different. So a significant difference is important to know, but the blood pressure you should treat to is the blood pressure that's treating the brain, which is the highest one, not the lowest one, of course. Because I had a patient who I was looking at with heart failure, and when I measured their blood pressure in their left arm, it was about 70, and I thought, and I was just about to increase your heart failure drugs, oh help, what have I done? And I went to the other arm and it was about 115, and the reason why was they got a huge atheromatous plaque in their left subclavian artery. So in that patient, not only would we investigate that, but also treat on the left-sided, on the right-sided pressure. And if it's in AF, always do at least 3 readings. Use the highest blood pressure arm. Now, some patients say, especially women who've had a mastectomy, oh, no, you're not allowed to take the blood pressure in that arm. And they are very, very voluble about this. I had a totally obsessional, but very pleasant, retired GP, highly intelligent, who'd had a mastectomy, bilateral mastectomy, and had lymph nodes removal. And she said, no, I refuse anyone to take blood pressure in my arms. So I then showed her the literature on this, and eventually persuaded her that taking a blood pressure for a minute or 2 is not going to give her recurrent cancer of the breast. But there's no point in getting into conflict and argument with the patient. You can give them the literature, but at the end of the day, sometimes you have to back down and say, fine, and then you'd have to measure the blood pressure in the leg. But I don't think that that's the best thing to do. The blood pressure in the leg, 15/10 higher than the blood pressure in the arm. And then I'm very keen, none of my patients have a blood pressure just sitting, I stand them up. Now it's harder in a stroke patient, of course. And we talked last time about supporting the arm at heart height when you do this. In younger people, you need to not only measure blood pressure on standing, but wait up to 5 minutes for a blood pressure drop. Whereas in older people, the blood pressure, if it's going to fall, will have fallen in 1 minute. And I think this is really important in at least every now and again in people, to make sure they're not dropping their blood pressure in the boots, especially if they're complaining of lightheadedness. Now, traditionally, people have looked at postural hypotension and said supine to standing drop of 20 or over 10 or more is what you look for. But it's very difficult to get everyone supine, and it's an artificial situation to put them in bed. So in my outpatient setting, for instance, I use the Journal of Hypertension guideline of 15/7 would be a significant drop. But of course, if the drop is down to a systolic of 90, it doesn't matter whether it's 15/7. If they're feeling lightheaded, as systolic at 90 on standing, that's too low for them, isn't it? So that's what I would tend to do. So the patient's got a home blood pressure monitoring, whether it's one that's been provided by BPM at home or not. Is the machine valid? Look on the British and Irish Hypertension Society website, make sure it's a validated machine. We prefer not to use the wrist monitors because of the lack of reliability or the lack of equivalence to arm blood pressures. But someone asked last week, well, what happens if they're very, very fat and you haven't got the right cuff, or that's all they've got? Well, what you'd have to do is measure the blood pressure if you can with an upper arm monitor and a cuff of the right size and see if they are valid. And I have some patients who, when we do that, their wrist monitors are valid, but it's not our preferred choice. As we mentioned last time, please use the correct cuff, aiming for the bladder of the cuff to go around 80 to 100% of the upper arm circumference. Now, in the BPM at home, both the M2 and the M7 have got cuffs that go up to 42 centimeters, but we haven't got cuffs for them for 42 to 50 centimeters at the moment, or hardly any. And remember, we talked about cuff placement, the lower edge of the cuff being 2 centimeters or 2 finger breadths above the elbow crease. And is it comfortable? Sometimes say, ouch! And the reason is that you've got their skin caught in the cuff or in the place where it bends, all sorts of things. So please don't just soldier on. Just find out why it's uncomfortable. Some people just hate having blood pressure measured, as you know. We talked about this last time. Make sure they're silent. Blood pressures of up to 50 systolic elevation I've seen before now. Remember sitting with the cuff at heart height. Remember about duplicate readings, and if there's a difference, use the higher arm. And the thing about stroke patients is, of course, can they put that cuff on without help? It's surprisingly difficult for an able-bodied person to do that. And sometimes you've got to see, can you do it? Can you help them to learn to do it in a different way? Is there a carer who can put it on for them? And even if you think they've been able to master the art with the cuff in the right position, rotated the right way, try it a second visit, and if preferably train a carer to help them. But that's not always easy, is it? And what we've got to think about now is, what are we going to do with those readings? Where are they going to write the paper, the results? Is there a spreadsheet they've got that they can use? Have they got an app on their phone? Is the patient able to do it if they've had a stroke? If they do have a piece of paper, does it fall to the floor and can they reach it? Have they got something to write on it? Can they write legibly? Those are problems to be overcome, and I'm not sure that we have a solution to those. And I'm hoping that between us all, as a group, we can come up with some solutions to get around these problems, especially in the stroke community. You've got to have an agreed strategy once you've got over that of how often you're going to do the readings, both in terms of for how many days in a row. The minimum would be for 4 days in a row. Anything between 4 and 7, as I said last time, I aim for 5. And that would be 2 readings before medication in the morning while seated, and 2 before retiring to bed at night. And how are you going to send the results? When are you going to send the results, and where are you going to send the results to? Ideally, someone who's advising on therapy would like to see the blood pressure readings already averaged, rather than have to start averaging themselves, because it takes unnecessary time to do that. So that has got to be faced. And also, whether it's 130/80 or 140/90 in clinic, set the target. It's best that the patient knows what you're after if they can understand and they're with it, in terms of being motivated, because it will motivate people towards it in terms of not just the medication and taking it, but also lifestyle changes. So this is important to train, inform, and motivate patients as to what this is all about, why we're doing it, which is why I've done all those previous slides to say, look, this is an important thing. You don't want another stroke. 41% mortality for recurrent stroke. And we haven't set this up, but we've got to think of, are we going to have a helpline for patients or carers? We haven't got one at the moment. You know what it's like? You ring up your primary care physician, and first of all, you have 90 seconds of telling you why you shouldn't be phoning if you've got COVID. And then after the first 90-second warning, then you're given 9 options. 1 for results, don't phone till 10 o'clock, secretaries after 2, and so on. And by the time you got to the 9th and pressed whichever one you wanted, you probably are unengaged at the moment or whatever. It's sometimes very difficult, isn't it? So how are we going to cope with that? When's your next visit to get the patient's blood pressure, or the next visit for a treatment? And who's agreed to pick up these blood pressure results and act on them? These are things which will have to be solved. It's no good just saying, here's your home blood pressure, let's measure it. You've got to decide what you're going to do with the results at the end of it. And please, just because they're on pills doesn't mean that we don't stop doing everything else. Alcohol, I don't know of many of my patients who had strokes who are addicted to alcohol excessively. Some people have snowstorm meals with excessive salt, and certainly if they can't take no salt as a flavouring, then low salt is only 30% sodium chloride and should be considered as an alternative. Blood pressure in cold environments is higher than warm ones. So in the MRCP mild hypertension study, the blood pressure in the summer was on average 10 millimeters lower than the blood pressure in the winter. So in very hot weather, blood pressure drops, and in one very hot summer, most of my hypertension patients, I had to almost stop the blood pressure treatment, and when they came back in the autumn, they needed the blood pressure treated more. And so you have to be aware of seasonal variations and make adjustments. And while we're at that, it's not going to happen at the moment, but if someone goes somewhere and they get diarrhea and they're on an ACE inhibitor, then a tip is stop the ACE inhibitor until your diarrhea is settled, because otherwise you can get significant dehydration and renal dysfunction. Constitutional, think of obesity and sleep apnea. Are you just going to look at it and say, try and lose weight, which never seems to happen, or are you going to try and help them? You've seen a recent licensing of a drug called semaglutide to help weight reduction. And I've already mentioned that if patients have got raised blood pressure and impaired glucose tolerance, then an SGLT2 inhibitor, a gliflozin, might be a drug of preference. Avoid excess salt, avoid excess alcohol, avoid excess calories, and then what about substances? Well, the OCP, not only a cause of stroke, but also a cause of, in some people, of significant hypertension. I'm not sure there'll be many stroke patients taking testosterone and androgens, but certainly there are enough people with hypertension out there who've do that. And any form of steroid, even excessive steroid on the skin, can have an effect, both in terms of inducing diabetes and causing Cushing's syndrome. Growth hormone, not likely in this community. Non-steroidals certainly can put blood pressure up. Some monoclonal antibodies and cyclosporin and other immunosuppressants can put blood pressure up. And antidepressants like venlafaxine can put blood pressure up particularly, and slum-simming drugs and monoamine oxidase inhibitors. Erythropoietin, given particularly for people who've got low hemoglobin with renal failure. Triptans for migraine, and some cough, cold, decongestants. Unlikely to cause significant blood pressure elevation, but just worth noting just in case there's taking a lot of it. And then lots of caffeine, lots of alcohol. Cola has been recorded as putting blood pressure up, and some people who are licorice-holics can have a significant Cons-like hypertension syndrome. St. John's wort, given for depression. And all of these things, some people take. I had a patient the other day, and I've just going through what they were taking, and they were taking lots of cohosh. I thought, and they were taking it to help them sleep, but the trouble is if they're doing this, but it was not doing them any good in terms of their other treatment, but they thought it was okay. So what can you do by lifestyle modification? And this must be much part of what we advise. Salt reduction will give you a 5/3 reduction in blood pressure on average. Weight reduction, for every 10 pounds weight, 7/6. Exercise, when they can get to aerobic exercise 3 times a week to the point of breathlessness, would be 10/8. Alcohol reduction, for every reduction from 3 to 1 or 3 to 6 to 1 to 2 drinks a day, you're talking about 4/2 at least. And of course, the best diet is something called the DASH sodium diet. That's the dietary approaches to stop hypertension, which is better than salt reduction alone. And which, if followable, it's particularly good in nuts and potassium, low in salt. It's the most effective diet for reducing blood pressure if people can comply. And don't forget the other things: fun, family, friends, feelings, faith, and then fatigue. Fatigue, because people with stroke often get tired, fatigue with being nagged, fatigue of having to do the same old thing all the time. Motivation is much of what we have to do, isn't it? And you'll know that even more than me, because you're there every day doing this. And I'm going to stop there and take any questions and hope I don't get as embarrassed as last time.
I'm sure not. I think somebody else has also commented that there isn't necessarily always exact clinical consensus on some of these things. So thank you for that excellent walkthrough, expert walkthrough blood pressure management. 2 questions that I can see. The first is from Jackie. For the 4 readings a day, can you confirm it is ×2 before medication and ×2 before bedtime, or once pre-medication and twice at any point during the day, and then once pre-bed? So for the 4 readings a day, I think it's kind of when? Well,
in the hypertension community, in terms of routine blood pressure management, it's twice sitting, arms supported, silent, waiting 5 minutes. I'd wait 3 in the morning before any medication, which will give you your trough blood pressure, and twice before you retire to bed. Now, if people have got marked, I have some patients in whom the blood pressure changes in the day and they feel very weird about midday. So I've asked them then to do a 3rd reading, a pair of readings in the middle of the day. But no, it is not one before and one after. The point of the morning reading is it gives you your trough blood pressure. In other words, what the least effective of the drugs are before you take them. And if you were to take one afterwards, of course, blood pressure may be dropping within 2 hours and reaching a low point 4 hours later. So whilst that might be useful in terms of adverse reactions, in terms of prevention, the strategy is 2 before you get up and 2 before you go to bed at night. And then I had a patient the other day whose morning blood pressures were just not controlled and whose evening blood pressures were. And I found out what they were actually doing was they were taking after their evening drugs, which I thought they were taking at bedtime, they were actually taking them about 2 o'clock in the afternoon or to 6 o'clock. And so the blood pressure drugs were not working in the morning and they were lowering far too much at night. So for many people who then forget to take their pills, and forgetting or non-concordance or non-adherence is a big problem. What I say is, look, if you clean your teeth twice a day, put your pills by your toothbrush, and then at least you might remember to take them. And I think we have to look at concordance or adherence. Do the patients take all their drugs? And it's worth a friendly chat, you know. So do you sort of question like, do you manage to remember to take your pills every day, or how many days a week do you reckon you forget to take them? And some patients say, is there any you don't like taking? And they say, oh, yeah, I don't particularly like that one. I don't know why. I don't like the color or something like that. But a non-threatening chat saying, is there anything you don't take and how often do you don't take? And if you take less than 80% of your pills, they're not going to give you antihypertensive control. So that's one thing. I hope that helps, Sarah.
Yeah, and just to say that you covered measurement quite extensively, didn't you, in your first webinar?
That's right.
Just a question from Joe Stevens from Bury. How often is it feasible to ask hypertensive patients to titrate their own blood pressure medications? Should this be something that is considered? She's never seen it, and if so, and with what safeguards?
Well, at the moment, there's no routine agreement. That study of the self-titration was done in Oxford under trial protocols, and that it's possible, but it's got to be agreed, hasn't it? And it's got to be agreed with the whole practice, and they've got to have their agreed protocols for it. So at the moment, no one that I know is doing it. Sometimes I'll say to the patients with a letter to the GP saying, on these blood pressures, if your average is still above 135/85 after 2 to 4 weeks on the first drug, I'd recommend, for instance, you add drug 2 or double drug 2, and then remeasure 2 weeks after that. But that's as long as the primary care treater is happy for me to do that. So that's a joint agreement. And one thing that you'll see in the new guidelines we're coming out is that it's more effective to add a second drug than it is to double a first. In fact, it is always more effective to add a second drug than double a first. So don't go to top doses of amlodipine as monotherapy. You do better to stay on 5 milligrams of amlodipine and add an ACE inhibitor than you would be to go to 10 milligrams of amlodipine without an ACE inhibitor, not only because of less blood pressure reduction or less effective, but also even more adverse reactions. Hope that answered your question, Joe.
She sneaks another question in, which I'll quickly provide. Do you give antihypertensive at bedtime in any circumstance? I think there's some research to say bedtime is good.
Right. Well, the study came from a chap called Ramon Hamida in Vigo in Spain, and this study is called the Hygiea Trial. And it was a large trial of 22,000 people, where over 12 years they'd looked at blood pressure, and they gave all the blood pressure in the morning or all the blood pressure in the evening. And if you look at, first of all, at their outcome, it looks very convincing that all the blood pressure could be given in the evening. However, if you then look at further copies of the same journal, there's quite a lot of discussion about whether the trial, the science of it and the statistics. And so at the moment, I don't think you can change your whole policy based on one trial, especially when some of the leading critics have been very voluble in the same journal criticizing the trial. And so there's a study in the UK called Treatment in Morning or Evening Time, which data's been collected on and should be published, I hope, in the not too distant future. And that will look at the same thing, where in the UK population, we've either decided to put treatment in the morning or the evening. Now, if that says the same thing, that's fine. But my feeling, Joe, is that whilst the Hygiea study looks on the face of it to be an excellent study, it is a single study from a single place in a single situation, and it has been questioned by some leading critics. I think wait for the second study. Now, I have patients who I know their nighttime blood pressures are high, or I know their morning blood pressures are significantly higher. So I have no hesitation in then saying, well, we'll take your ACE inhibitor in the morning and your amlodipine, which is a very long-acting drug with a 36-hour half-life, take that at night. I've no problem with that. But to move the whole lot from the morning to the evening, at the moment, I don't think the jury's out. Don't rush into it unless you've got a very good reason for doing so.
Thanks for that. I'm conscious of time, but I think given we've had a few technical problems, I'm sure people won't mind a couple of minutes more. Just a final question then from Pamela. Is the ideal time for the stroke 6-month review visits at home in the morning before people have taken their pills, do you think?
You're asking me to think, aren't you? On the spot. Well, yes, I don't know. I think the answer is you can't see everybody in the morning, of course, but there'd be a lot to be said for it in one sense. But are you asking them to not take their treatment that morning? And I'm not sure that I can justify it either way. I'm not experienced at home visiting for patients with stroke, and I think that that's the sort of question that can come out of this. And I'm hoping that you will all post up some questions so that we can discuss and refine what we do and come up with a better option. You can see there's some holes in what we know. There's some holes in our protocols that we haven't decided on yet. And this is a team game. I know something about blood pressure, and some of you know an awful lot more about stroke patients. And I'm hoping that together we can work on this and come up with something which will help everybody. And you, I, and all our patients and their carers will be happy with it.
Yeah, thanks for that. I think the blood pressure at home, which is mainly being run through primary care, I think it will be really interesting to see how it fits within the stroke pathway. So we are hoping to collect some data to support that. I'm just going to finish by thanking Dr. Philip Lewis, who is a cardiologist, as he said, from Stockport, for giving another excellent presentation, and we're hoping to snaffle him to perhaps do some other training for us during the year, and we'll continue working on the blood pressure initiative that we're involved with. Thank you all for attending, and as I said, you should get an email tomorrow with the information. So sorry we've overrun a little bit, but hope to see you in future on another of our webinars. Thanks and goodbye.